if you ask why do I love complex cases, early in my career I became a resource for a surgeon who got a lot of complex cases, and I got one better, and he was like, "Perfect, you're getting them all." Hi, everyone. Welcome back to the podcast. Welcome, all new listeners. Welcome back to those who have heard my content in the past. Happy New Year's Eve for those of you listening around the time, depending on when you obviously listen to this podcast. It could be a year from now, 6 months from now. Nonetheless, I am here on New Year's Eve giving this podcast, and I am excited to talk about these three complex case studies and everything I've learned from them. And I think they can help you out tremendously in that you may never see these cases ever in your professional career. However, you will know how to manage and be ready for complex cases. And I'll tell you more about that in this podcast. Before I go into the podcast, what is better? What's new in life? And somebody asked me recently, they said, "Why do you always do that? Why do you talk about life?" I'm here to learn about, insert topic. I think it's important. I think you have to know that I do it with all my team, my staff. It's very important. I think that you have to understand that in the game of physical therapy, whether you're at a clinic you really love, you're in a position you really love. I think you have to remember that people are always important. People are the reason why we live, why we work, why we are doing anything in this planet. And for those of you who are new to my podcast, that might be a little heavy for you when you're like, "Hey, I just want to learn about some case studies." I do it with all my staff and all my team, and anybody that I interact with. I think it's important that you check in with them. And anytime a client or a patient comes in, I'm like, "How are you? How's life?" I think it's important. It sets a tone, sets a positive platform, positive focus. And so anytime we start with a meeting or somebody says, "Hey, can I talk to you real quick?" "Yeah, of course. How are you? How's life?" Set the tone, be interested in the people you interact with, and then all the problems are secondary to that. I truly believe that. And it's actually one of our core values in our company, and we're adding it actually into kind of the way we set the tone with people who interact. So anybody who walks through our doors, "How are you as a person?" And then we'll talk about your ankle and everything else afterwards. So I think it's very important. Nonetheless, that's my long-winded answer on why I always talk about life. I think it's a good positive focus. Life for me is great. It's busy. We traveled recently, and I had my kids had an ear infection and random things that I haven't ran into as a father, and I'm learning along the way, and trying to be patient and learn the process of, kids get different illnesses at different times and learn how to manage that. And I think it's the same with adults. Sometimes when patients come in, it's just a new thing. They've never had it. They've had an earache, they've had a cold, they've had a fever, but they haven't had knee pain before. They haven't had back pain. This is just a new form of new thing in their life. And kids are recovering. I am back to training. I actually just trained. I did a workout a little while ago, and I have, for those of you on YouTube, I tore a little bit of my hand. But yeah, life is good after all. If you weren't on my last podcast, I announced that we are officially doing 5 courses next year. I am going to be hosting 5 courses at our San Diego location for those of you who are interested. I'm only going to do like 10 people. I want to include my team in there. They get a large amount of the seats, and I want to make sure it's intimate and everybody has a very personalized experience, very close, intimate like feel to it. I really want to make sure that people enjoy it, and the courses are going to be different. They're nothing like you've had before. I promise you that. They are going to be focus on growth, on professional growth, and what you need to do in your steps in your career based on where you're at, on what you need to do to add into your spectrum of services that you provide. And if you're new to my world, I really think that physical therapists have a place in healthcare, and I want to expand the skill sets that we have. Most people have to go through a residency or have to have a certain mentorship of some sort. I don't even know where you can get more acute injury management training, and then more strength and conditioning later end stage rehab progressions, not just plyometrics, but like programming, strength and conditioning to help people get back to whatever it is that they want to do and feeling confident about it. I'm a big fan of collaborating with team members or other services, massage therapists, personal trainers, physicians, whatever it is. But if I can dabble and have a little bit of their skill sets, I can help the transition until they find somebody. Or if you live in areas where there's not a lot of resources, you could be that resource. So my vision is that. So the next course is going to be acute injury management. That is on March 12th and 13th of 2022. I am excited to host that. 10 people max in person, no more. And there will be virtual options. So if you are like, I live in Texas, I'd love to be part of it, but I want to be able to tap into it remotely, no problem. No, the second one I think is going to be in June, and the last one I think is in September or October. And then I have 2 barbell courses, management of the barbell athlete, one in April and the other one in, I think, November. So plan ahead and let me know if you're interested. Dr. Chris at drchrisgarcia.com. I have put this on my newsletter, so I'm excited to see you guys. All right, on to this podcast. Probably the 3 most complex cases that I've ever seen. That's a bold statement. 3 of the most complex cases that I can remember that really stuck with me and improved the way I treat and manage people. And I'm going to go through these, and I don't want to get stuck in the diagnostics. I want you to take a step back and really think about what you would do when that person's in front of you and how you would plan accordingly based on symptoms, based on their presentation, and based on their goals, and then where you would take them. Because these really, some of these, one of these was early in my career, probably 3-4 years in, and the second one was about 7 years in, and the other one was about 9 years in. So large gaps in between. So even with that many clients and patients and athletes I've treated in between, man, they were tough, and I'll tell you why. So I'll start with the first one. And this one was I know this person personally, and I was honored to be able to take care of this because they trusted me with it, and they felt like I was the best fit for it, and I never take that for granted. And so this athlete, 30 years old, comes in with chest pain, very pinpoint chest pain. And if she listens to this, you know, I really appreciate being part of this medical journey. And there was a long-winded timeline for this person, trying to find answers and just frustration. And they started having chest pain, like intercostal region. But then they started being able to. It was after a certain amount of, I think, push-ups or ring dips or bar muscle-ups or ring muscle-ups. Either way, a large tug at the chest wall. They're a 30-year-old, very active, and they are very aware of fitness, and their profession is sitting a large portion of the day, but very, very active. Training 1 or 2 times a day, several times a week, functional fitness, strengthening, bodybuilding, you name it, a little bit of everything. So somebody who's very active, very motivated, very knowledgeable. So chest pain, insidious onset times at least a month, and immediately after doing ring dips, a large volume of them. And so you think like, okay, costochondritis, but then they started pointing to like very lateral to the costochondral region, inferior, underneath the ribs. So almost at the apex or at the bridge of where the cartilage comes into contact with the bone, but underneath the rib. And they said it was stabbing, sharp, and debilitating, and hurt with breathing, hurt with any form of chest contraction. So any form of like walking and increasing heart rate would give them pain. Well, you might say, okay, well, let's rule this out. I mean, let's make sure there's no cardiac component to it. They did. They cardiac testing and any signs of cardiac involvement were ruled out. That was done. Then, okay, well, let's get some imaging. X-rays, clean. MRI, clean. And I think they even had a CT scan. They had blood work. And they had the test. They had any test possible. They just did it. And by the time they saw me, I think there were months in, maybe even 4 to 6 months, maybe even longer than that. But just come in with frustration of what is this? Nobody could diagnose what this was. And you got to ask, is this musculoskeletal? Absolutely. It would hurt with standing, being supine. Prone also hurt, increasing expansion of the chest wall. So there's a mechanical component to this. So you're in your head, you're thinking like, okay, well, what would I test? What would you do with this? So obviously you want to do palpation, you want to do all these things. But before I jumped into the case, and if you ever see me treat, or if you want to see me treat, or you want to understand my framework, before I jump into treatment, I think that's the worst thing you can do right off the top. Most people inherently, we want to like, what is it? Let me touch, let me feel, let me rule this out. This is why this is a complex case, and this is why you will be set up for success if you learn from my mistakes and from the story. Before you go in solving problems, before you try to find a leak in a house, you got to understand the story. When did it happen? How often? And ultimately, you got to figure out what their goal is. Why are you coming to see me? And you as a physical therapist, your first instinct is, well, they want to get rid of the pain. They want to figure out what it is. No. What's the reason behind that? In this sense, they wanted to be able to get some fitness in, like be able to exercise. Like they understand that the pain is there. They've had everything ruled out. They'd love to know what it is, but they also want to know what can they do to maintain some form of fitness despite this, and is it going to make it worse? And then how do we minimize how much more worse this gets? Those are different goals than get rid of the pain. Some people understand they're going to be in pain forever or pain for a long time. They understand that. And you as a clinician, you know what you do? Because we've been like, for those of you on my YouTube channel, I'm hitting my head with my finger. We've been not brainwashed, but we've been coached and taught that pain is life. You attack it, you abolish it, you eliminate it, you alleviate it. And I have to ask, after treating professional athletes their entire life, or my entire career, and a large portion of their life, I've learned that a large portion of the community doesn't expect to ever be pain-free. And if people understand that they don't necessarily need to be pain-free, well, what does that do for our profession? What does that do for our career? That means you have to shift the way you approach somebody and say, I understand that, wait, you don't think you'll ever be out of pain? Why would you ever want to change their mind? Show them. But you don't need to change their mind. What you need to do is ask, well, then what do you want to do? Oh, I'd like to be able to train at a high level and not increase the rate of pain. I understand I'll be in pain at some point, but I'd like to just be able to continue training. Oh, I see. That's a different goal than getting you pain-free. Because now I have to understand how to program and how to manage fitness variables, frequency, intensity, time, and type, to be able to keep your base level of pain at or below where your resting is. That's art. That's combining strength and conditioning. That's combining physical therapy. That's combining rehab, a little soft tissue, a little bit of like the psychosocial component. That's like managing. That's like coaching on some aspect. And I think what you need to understand is that some people never want to be some people don't ever think they'll be out of pain, and some people might not be out of pain. And what I mean by that is, if you've ever worked with professional athletes, they're always hurt. They're always hurt. You really think you're going to have a professional athlete pain-free all year long? Impossible. Impossible. All the money in the world. Because if they play a contact sport, you can't protect against that. Those are unpredictable. If they play a non-contact sport, you can try and, if they play tennis, you can try and prevent ankle sprains as much as you can. You do all the proprioceptive training. You buy the best ankle braces, the best shoes. But there's also like, what if it rained and has a little slip on the court, right? Like, there's always going to be instances where there's trauma and overuse. Just the volume at that level, there's always something. So the better question is, what's the goal? So for this athlete, they want to be able to know, what can they do to continue fitness, and how do they not make it worse? Those are two goals, and the lesson learned there for sure right at the top is ask better questions to understand what their goals are. Don't assume that pain-free is the goal. That's not for everybody. And I think that's really biased of you to do that. Just because our teachers and academia tells you that doesn't mean that every human on this planet does. And let me flip this real quick because I want to stay on this topic. For those of you who work out, I have a lot of team members who are very active. Some into Olympic lifting, some into running, some into functional fitness. And I find it ironic that some of us love to train and exercise, and when we get hurt, we think like, oh, it's just normal, it's just part of it, and all you want to do is continue exercising. Yet when a client or an athlete or a patient comes into you, you don't even think like that. You think it's okay. Let's just take 2 weeks off, and then I'll give you all the exercises, and I'll help you get pain free. Versus, man, if that was me, I'd want to exercise tomorrow. Let me help them figure out how to exercise today or tomorrow. We're not programmed to think like we want. We're programmed to think what we're taught to do. And I think that's important for you to switch up. So for this athlete, I asked, what's the goal? And they said, help me out. I said, okay, no problem. Let me go through a battery of tests to make sure this is mechanical. I got a rule, like, if this is in my scope of practice. And we went through testing. In my head, off the top, I was trying to figure out what the fitness level is, what was the baseline prior to this, so I have a reference point of how active this person was. And then I just went through a little bit more questions. And I discovered that it does hurt with elevated heart rate, which means elevated breathing, which means that any time that she took a deep breath in, it increased her pain. Lying supine also hurt. Lying prone also hurt. Lying on the side with the affected side up did not hurt. So we had to figure out, does this hurt with sleeping? Yes, and her arms had to be propped or in a certain position to get comfortable. And ultimately, the quality of life had like exponentially been affected because this person couldn't even sleep, stand, sit, exercise without debilitating pain. And this is somebody who's mentally strong, can take a lot. So there was something going on, and the medical workup for the cardiac component was ruled out. So that makes my job so much easier. Now I know that this is my world. All I have to do is rule that it's mechanical or not. And blood work was all negative. Cardiac screening was negative. Endocrine was also evaluated, and that was unremarkable. All right, great. That's in my wheelhouse. Let's do this. So I started with providing, I wanted to know, is this a compressive problem or a distraction problem? So what I started doing was I just did apical breathing, and I wanted to see if we did like bucket handle versus apical, if that changed anything. I then did compression on the ribs, like a squeeze test, just on the lateral aspects of it, to see if providing distraction on the anterior portion would give her more or less pain. Doesn't matter. Like, we're always stuck on, does that make your symptoms better? Who cares? Do it better, worse, or the same. And as long as you can affect it, that's beautiful. If you make it worse, oh my goodness. I have so many PTs that I mentor that they say, hey, I made it worse. I'm like, oh, good for you. That's beautiful. We can change it. That means that there's another component that we can like actually have an impact on. So even if you worsen things, that's okay. It's mechanical. And especially when you have a complex case, that's beautiful. You have a sign, a comparable sign to go towards or away from. So I tried distraction, and ultimately the one thing that we knew could reproduce it was direct palpation on it. And I almost did a scooping technique. So when you're on, this is a female, so you really have to be careful, have people in the room and verbalize everything that you say. Why? Because you don't want it to be misconstrued. People have a misconception of what you're about to do. So this person wore a tank top. They're very comfortable. And I just started palpating from the top, compression on the sternum, abdominal breathing, no change. So I'm trying to rule out top, bottom, medial, lateral. Where is this coming from? And so what we did was we tracked compression along the same rib, and compression felt better. And the weird thing is, I scooped underneath that rib and I put pressure, and that elicited the pain. And I'll tell you what, it's one of the rare cases I've seen, and I've never seen anything like this. I've seen stress reactions in rowers. That's very, very common. Elite level rowers, Olympic level rowers, that they have rib injuries. But this was not rib. This was something else. And the cartilage was clear in terms of testing, like compression testing. So we know that it's near the corner of where that rib meets that cartilage. Cartilage is all ruled out. Sternum negative, abdominal breathing negative, high threshold breathing or neck breathing negative, compression testing on the ribs negative, distraction testing negative. So if somebody's prone, why does this hurt? If somebody's supine, why does this hurt? So then we started looking at, okay, so if I scoop underneath, that makes it feel better to compress directly on the rib, but to scoop underneath, it would elicit the symptoms. And I said, it's definitely rib or any form of neurological component that's below the rib or sub nerve or any artery vein following that. So we started doing some research, and second session, I knew I had to make some differences. So I did some research, and there's not a lot on this, but it comes down to the global term that we figured out was a form of intercostal neuralgia. And it does exist. It's a very rare case. And did we get this person back to training and fitness? Yes. How long did it take? Probably over a year. It was debilitating to this person. And as a clinician, that breaks your heart, because if you're like me, you want to conquer the world. You want to solve every single case. And there's a couple lessons I learned off of that. One, ask really good questions on what their expectations are. You got to know what the expectations are, because you can't assume that in your world it's just pain. They might say it's pain, but understanding deep below that, they might say, like, I just literally want to be able to sleep. So your objective testing is number of days of sleep versus number of days of pain. Those are very two different things. I know that you see them as black and white, but they're very different. So what made the greatest impact on this person? Actually, believe it or not, I don't want to receive comments or in Instagram DMs. Taping was pretty massive. Taping and providing a scoop. So if we look at any form of rib as it attaches to the sternum, below that you have a small nerve that comes underneath below, and that rib protects that. It's a little shallow groove along the way. And ultimately, compression, lying prone or lying supine, the rib would push back against that nerve. The weight of the lungs and everything else in prone would also push against that. But lying sideline provided a little bit of distraction and gapping, and that's why that felt better. And anytime that they took a deep breath in, it pushed against that nerve and into everything else. So why did it happen? That's a really tough question, because they ultimately did a high volume of dips, push-ups, ring muscle ups, bar muscle ups, but ultimately pulled and provided strain across the intercostals, but then also irritated the nerve. Either they bumped it, they put a lot of compression on it, the high rate of breathing, intercostal muscles pulling on that. I don't have an exact answer, and I don't know if anybody else does. But the client, the athlete, was very, very excited to obviously improve. And the lesson I took away is that you got to be honest and transparent with the clients and athletes that you work with, and let them know how familiar you are with it, and then what you intend to do, and how long, with an expected timeline, you expect the recovery to be. And you got to be honest. And an athlete, they appreciate that, because they need to set the tone for whatever they're planning coming up, events, competitions, standards, whatever it is. And this person really just wanted the question became, can I fly? And I know that's weird to you. Like, why does that matter? Part of their job was to be able to fly to different places and meet with people. And the question became, is this safe for me to fly? Do you think this is going to get worse? Can I last, 3 to 4 hours on a plane? And if I do, it debilitates me. So I need to be on my back. I need to have medical resources available. And we went through it. I think in the end we said no. We said it wasn't the best decision. And it was a big decision for this person. And my first lesson was ask better questions into what their expectations are. Number two is um, you got to be transparent about how familiar you are with things. I think people would appreciate that. If you're not, you got to be honest, but here's what you got to tell them: the truth. If you've been with me long enough, you know I'll find an answer. I'll find it, and if not, I will dig and I'll try and create one. And my athletes will appreciate that, and your athletes too. And so if you're already doing that, great. You're on the right path. If you're not doing enough of this and you say, if you use the words, I don't know, you got to be careful because they might think that as like you literally are not intelligent and you don't know what you're doing. What you need to say is, I haven't seen a case like this before, but I've managed a lot of cases like this, and I'd like to help you out, and I'm confident we can push you in the right direction. I'm going to do some research on the back end. When I see you next time, here's what I expect to do: give you a timeline, a better understanding of what's going on, and be able to help you answer the questions that you need. And what that does, now they're confident. Now they're confident in your skill set. And an athlete, that's all it is. If you've ever had a really good coach, if whether you play baseball, basketball, whatever it is, coaching is hard. If you've ever been in really tough scenarios, fourth quarter of something, down by 20, how am I going to win this? Down by 3 touchdowns and 2 minutes left, you're like, guys, I've never been this before, but I know we can do it. That type of confidence tells you, man, I believe it. When you're down, you need somebody to pick you back up, but they can't. You can't lie. You just got to tell them the truth. So being transparent and honest, and setting the tone, letting them know what you plan to do. So that was really, really, really tough for me. Intercostal neuralgia. Man, if that comes your way, send me a message, man. Dr. Chris at drchrisgarcia.com. That is tough, and I will take that on any day now. I feel very confident that I can manage that. I might not be able to get them pain-free, but I can set them in the right direction and maybe get them the resources they need. In the end, I think they actually tried I think they tried an injection, lidocaine injection, to see if it was neural. That actually became negative. The one thing that they loved was the soft tissue to generally like neck area, abdominal work, just free up the rib cage. We actually did T-spine work. We did paraspinals. Like, why would you work on the paraspinals? Why? Because you're going to free up the T-spine. You're going to free up any rib compression that's actually forcing compression on the anterior component, help everything relax. Imagine like a barrel just pushing pressure on that, and so all you're trying to do is relieve and alleviate that. So working on the neck, sternocleidomastoids, scalenes, abdominal work, intercostals, providing some tape. I just didn't irritate it. We worked all the way around the compressive area and just freed up everything. And they loved it. I mean, it helped them temporarily, and it was just temporary pain relief, and I think that was a Kickstarter. But ultimately, then providing some tape. We looked into even like AC joint harnesses just to see if that would help or provide any form of relief, and it didn't. Then we provide different forms of, posterior, like shoulder maintenance, like even T-shirts, or I know there's several types of like compressive shirts that improve your posture and ultimately just provide some relief across that intercostal region. That didn't provide too much support, but always looking at external devices, always looking at temporary pain relief, taping techniques, medication for them to consider, even though it's not our scope, just doing research to help them, send them to the physician to look into things, what type of injections, being the resource for them, and being an advocate for them. Your job doesn't stop at the musculoskeletal component. Your job stops when you quit. Your job is to then research what else they can be doing and sending them to the specialists that they might be interested in seeing and help them point them in the right direction. Don't give up when you don't find out it's not musculoskeletal. Help people in the right direction, because that's what you would do for your parents and your family. So intercostal neuralgia. The second one, deep perennial nerve. This was a couple years ago, 7-8 years into my practice. I had a pole vaulter. A pole vaulter came my way, looking to become elite pro, and very, very active, very fit, and they were having chronic shin splints, and it was on their takeoff leg. So the amount of stress that goes when you take a pole vault and you run as fast as you can, the braking force on this last step prior to that pole going into the ground, you to be able to take off, there is a significant amount of stress that goes through that foot, the toe, the ankle, the tibia, and so it's a hard land. And when you do multiple bouts for many years, the tibia takes a lot of stress. So they were post-collegiate and going professional, and they had been seen by multiple docs, multiple clinicians. So when people have seen, like, hey, they tell me, Chris, I've been to 10 PTs, 5 chiropractors, 8 massage therapists, 6 acupuncturists, um, uh, a guru from whatever country. I've done all this. I've seen all these people. I've had injections. I love those cases. I truly do. I'm actually that's my passion. One of them is to help people who haven't been able to be helped. Only because I can see it from a different light. I can help in the path. I can just be a resource to say, I'm hearing what you're saying. I wouldn't do that. I'd move it over this way. See that person a couple times. Move over this. Continue strengthening. Because I can see that ballpark. I can see like where the defense and offense can go. And this person told me they had seen a lot of people, and I said, okay, great. Like, what do you need from me? Because I can only do so much. If you've seen a lot of great people that I personally trust, how am I different? I have to ask that question. And they said, I had something happen, and they ultimately decided to go through surgical intervention for long-term shin splints. And this is the first time I'd heard of it. I've read about it. I've never met anybody who went through it. They basically had poor bone quality and so much stress that they elected to put in a rod down her tibia to help support it. And you got to say, I haven't seen this too much, and there are cases in research, random case studies, but providing that, the question becomes, is there long-term benefits going back to sport? That's the question. Okay, so now if you have a external device implanted now, can you perform, and are there good outcomes? And I would say yes, but here's the caveat. Here's the tough part of the case. At some point, the deep, let me write, it was the deep perennial nerve, deep fibular nerve, was affected during the surgery. And they no longer had motor function of portions or branches off of it. This is a healthy 27 to 35-year-old. Now what? You got to ask, okay, well, now what does that innervate motor-wise? And if you look through anatomy books, you're going to see parts of the extensor digitorum, different portions. So I didn't want to give it away, but extensor hallucis longus. So not brevis, longus for this person. So now, how is this going to impact their ability to perform? Extensor hallucis longus now at the IP can't extend. So if they can't extend the great toe, how is that important? With walking and ambulation, that's almost like a drop foot, but instead they had full motor function of the extensors of the foot, but they didn't have extensor hallucis longus on one foot, which was their lead leg. So imagine having drop foot, right? You typically can put a brace on that. But what about the big toe? How does it impact walking and running? If you're standing up right now, or if you're listening to this, I want you to walk and almost drag your big toe, and not think about picking up your big toe. But naturally, we do that every single step. And when you don't have this, it's like having a drop big toe. So how does that impact performance? Well, how are they going to clear the big toe? They have to flex their knee and flex their hip just a little bit more. And somebody who has drop foot, they have to hike, they actually have to have a lot of hip flexion, knee flexion to clear the ground. But if this person now has full extension of the toes, but no extension of the big toe, they have to hike up just a little bit, and they have to get used to that gait pattern. Some people will circumduct initially because they are tired of hitting that big toe. Essentially what happened was Their shoe wear pattern. They started to have shoe wear at the front of their shoe, and sandals and everything else, and they were almost tripping regularly. Um, Now, how safe is that to run? And the question became, can I perform at a high level with something like this? Wow, what a question. And finances are a component, and they have to consider, do they make this move to go pro and risk some things, or do they back off a year and risk losing funding to rehab this? And as a physical therapist, I don't know if many of us get this opportunity to help people through decisions like this. I don't make any decisions. I help people make better decisions. Why? Only because you're you're giving them all the information you have so they can make a better decision for themselves. So this athlete, I think we rehabbed for 6 months up to a year. E-stem, bone stimulator, you name it, we threw at it. I referred to a local acupuncturist, massage, mobilizations, taping, orthotics. We tried to create a little mini hammock or mini AFO for the big toe. We tried so many versions. We tried everything that I could think of, that I could research, the key terms I could find, PubMed, Google Scholar, local surgeons, neurosurgeons, um, and it became to a point where after a year, we gave it a year, and people ask me, how long will you give somebody to go non-surgical or surgery? I say, minimum 6 months, because I think that time and effort can go a long way, and surgery is a big thing, and cutting somebody's career is a long process. That's a hard process, and I don't want to do that to anybody. I think giving them chances and not hope is different, and giving them different options. And so we went a year, and nonetheless, it was very difficult to run, sprint, and walk without a great toe into extension. We were able to get activation, but it just would not go up to neutral. And what that meant was when she tried to clear the ground, she couldn't clear the ground up to neutral, and so constantly hitting that. So she had to do a higher stride, which changed her running pattern, which slowed her down. So when you slow in the game of pole vault, speed is everything, unless you're very, very tall. That's a different world, but it's just physics, and you have to be able to hit or run as fast as you possibly can. Your greater speed or momentum will give you drive to be able to pole vault into that with a sufficient amount of pole, and your experience and talent plus speed puts you into a really good position. So if you don't have that, it becomes very difficult to be really good at your profession. So because we had to alter her running mechanics, we worked on variations where we can play with the ankle, play with the knee, play with the hip, being more upright, being less right, upright, playing with different shoes, taping the thing, and it became very difficult for her to be successful. Her actual sprint times dropped because of all the mechanical changes that we were trying to do to make sure she cleared the ground. Safety became first, and when you're in the world of pole vault and you don't feel safe, it's very difficult to perform at your best, because the 99 to 100% difference is that gap is the difference between you clearing bars at a very, very high level, with the millimeters or centimeters being the difference. So my lesson learned there is, don't provide hope, provide options and choices that people make. And you got to work with them. Give them a chance of 6 months to a year to really make some change, but make sure you have a team with you. Find a local neurosurgeon, work with a local athletic trainer, work with a personal trainer, work with anybody, an acupuncturist, anybody, a massage therapist, anybody you can, to figure out, you're limited in your skill set. By law, we can't puncture skin in the world, in California. We can't. So find an acupuncturist, find somebody who needles, find somebody who has some skill set that you don't, because it's not the right thing to do to somebody. The right thing to do is find all the resources to help that person. So, the deep fibular nerve or deep peroneal nerve, that was AFO for the big toe. That was tough, and man, I could still see that athlete right now. And if they ever listen to this, thank you, and I'm honored to have that privilege to be able to help with that journey. And we had a lot of hugs and tears afterwards. And man, so memorable. But able to help somebody to the point where they feel like they've done everything possible. That's all you can do. All right, last one. EDS, Ehlers Danlos Syndrome. Early in my career, um, if you ask why do I love complex cases, early in my career I became a resource for a surgeon who got a lot of complex cases. And I got one better, and he was like, perfect, getting them all. He was a hip specialist, and this is before, sorry, not before, early on when people were doing arthroscopic hip surgeries. This is in 2009. And it was a big thing. Philippon out of Vail, Colorado, was doing a lot of them, and this person had studied with them. I don't know if it was a residency, fellowship, or whatever it was, and they became a hip specialist. And at the time, there weren't a lot of them in the Midwest, and this person became, they become well known. People would fly in, drive in from all over because they couldn't go to Colorado. He was a resource, and so he gave me one, and we helped them with hip pain and everything else, and then I just started getting complex cases. And when people fly in from all over the country to find solutions, that you got to believe that they have some challenges, they have some story, and they're not cutthroat, they're not clear cut pain relief type of cases that we normally see. And so I had to be able to apply better questions, figure out people's stories, so I can see how I can help, because I knew these people weren't looking for pain relief, they were looking for something else. So I have this. If she listens to this, I'm proud of you. This person was 13 years old at the time, and I'm still friends with her on Facebook. She was 13 years old, and she was she had hip pain, and they thought it was clear cut labral repair. 13 years old, had tried non-operative many times before, and they were adamant that this is what she needed. So they went through the surgery. But here's the problem, or the challenge. This person, prior to surgery, for 3 to 6 months prior, had been in so much pain they had placed her on crutches. And what they realized was this person became dependent on the crutches. They, dolled them up. They put color and stickers and all this other stuff, and it became an attention challenge. She got attention when she was on the crutch. So she's kept the crutches, and then she no longer put weight bearing through the hip because it was painful. But the problem is, you had this cycle where she no longer was in pain or less pain because she was in not weight bearing. But when people don't weight bear, how do you keep the foot off the ground? You hip flex. You flex your hip. In order to keep your foot off the ground when you're on crutches, you got to flex your hip. It's just mechanics. So what that did was increased her pain, but placing the foot on the floor already had a preconceived notion that actually caused her pain. So she flexed her hip and was still in pain. So she never put weight through the ground when she was on crutches, and she was flexed, so that was causing more pain. And the crutches were bringing her more tension. You had this circle of challenges at 13, very confused about what was going on, but knows that crutches help her, but putting weight on the ground hurt, but lifting the leg hurt. And the surgeon, before he went through surgery, said, hey, we also found out that through blood work and testing, she has EDS, Ehlers Danlos Syndrome. I didn't know what it was at the time. So basically, it's a connective tissue disorder, if you haven't researched it, and there's extremes, or a whole spectrum of people with Ehlers Danlos. Very stretchy skin, very bendy, very flexible on one end of the spectrum, but their connective tissue has a challenge being stiff or solid. It's very bendy is an easy way to see that. And so the concern was, if we tack down a labral repair, how will her connective tissue respond? And that was a concern. So that's why he wanted to do physical therapy as much as we can to see how she responded with just non-operative care. And so we went through the whole scenario. I think we did over a year of physical therapy. And the challenge also, and if her parents ever listen to this, I respect everything about the decisions you made. The challenge is the parents had a hard time. Do you give in to something like, do you enable something like this? Do you push through the pain? Like you, as a parent, what do you do? No, just push through it. You're imagining things. Go ahead and just do it. Work out. Do you push through the pain, or do you? Hey, it's okay. You don't have to push at all. If it hurts, don't do it. And that's really hard. As a physical therapist, our mantra is like load and go. Let's just like get you strong. Let's do it. And you have to respect, like, does a 13-year-old know what pain is and how to like gauge that? And the hard part, we didn't know, and the parents didn't know. So we tried the conservative route. If it hurts, don't do it. Then we, like 4 or 5 months in, like that wasn't working. We said, flip it. Let's load and go. Be aggressive, hard, 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 hard. And that made no difference. And so we were trying to battle with the parents. We gotta continue this. And we tried 6 8 months. That really made no improvement. Surgeon says, you know what? Let's do it. Um, let's do the surgery. And we went through with it. Liver repair. No difference in pain. No difference in pain. Still want to use the crutches. Hip flexion hurts, obviously. Now we know that liver repairs don't activate the hip flexor right off the top. It aggravates, especially in static positions over long periods of time. It aggravates it. And trying to get her motivated. We even went to 3 times a week. We tried the gamut, distraction techniques, rehab techniques, strengthening, neurological. We actually then had her see a sports psychologist to make sure that we were in the right domain. We were really trying to support this person. So we got the resources. That didn't work. And this person also, I don't know, this goes into it too. They were a middle child. So attention was also a big component of it to this. So you have a middle child going through, they're growing up, a little bit of puberty, and they're trying to find themselves. Now they have attention. Now they have two crutches dolled up. It's got colors and stickers, and it had even lights on it and all sort of stuff. Now getting attention. Hip flexion caused pain. Weight bearing caused pain. It got to the point where they were actually using her, pushing her in a wheelchair. So we weren't sure if it was attention seeking, uh, truly a complex case, EDS, uh, psychosocial. It was a very challenging case. And in the end, we found a resource. There's a group out in Boston that is a children's hospital that specializes in these type of cases. And I didn't know about this. I had to do some research, and the program is, I think it's almost a month or a week, 2 weeks, 3 weeks, 4 weeks program where the parents and the athlete or the patient fly out, and they immerse like OT, PT, sports psych, functional fitness, the physician, pain management. Oh, and the big thing is this athlete or his patient started taking meds at 13, pain meds, attention seeking, middle child, different forms of enabling early. We went hard and aggressive afterwards, post surgical, no relief, continuing on. Now, prior to going out to Boston, they start seeing like RSD symptoms, complex regional pain syndrome symptoms on top of the EDS. The leg became purple, like discolored. The whole leg became purple, and you can't fake that. I mean, it was like literally purple, like burgundy, and that also hit us hard. We didn't. What do you do about that? I mean, this all started with hip pain, and then one leg is now they're starting to sweat on one leg, plus it's discolored, and this poor girl went through all this trauma. So we sent her to Boston, trying to figure out how we can help her. So they work with the parents on um, like co-parenting and the psychosocial aspects of pain and how to manage pain. They also work with pain management in there, so they dose and they start to wean the person off of pain meds. Then they work on rehab, distraction techniques, mirroring, you name it. And they work with another surgeon there too. So we sent her there. Actually, the family moved there for an extended period of time. They loved the program. It was helping. They fly back, and we couldn't find an answer, but more things came out that this person had blood work done, and they had autoimmune disorder on top of that. The face became pale. They needed injections. Their immune system started to be affected. They started getting sick significantly. So there was a lot to this case, and it just so happened to be at 13. And I keep up with this person, and they're in and out of the hospital regularly. And what are my lessons? Sometimes pain manifests as different things. Now I approach, what has it changed in my practice? Now I approach youth athletes from a different perspective. Now I ask the parents more questions about their home environment, I try and frame it to understand where that child sees himself. What attention do they get? Are they good at sports? Do they want to be known at sports? What's their personality type? Has that changed? Um, not because I'm skeptical, because I want to have a better understanding of the story to see how I can help this person. And if there's yellow flags, I can hit them sooner. If not, I have a awareness in the background to be able to have that communication with the parents or with the athlete one on one. And for those of you who've never seen a case like this, you need to start asking questions and looking at it differently on what's the household environment and why are they coming to see you. Who's the motivator in coming to see you? Why? The parents or the athlete? Is it truly pain? Is it consistent? Are there mechanical symptoms? And do they really want to be there? And you have to ask that. And I work with those parents for I think 2 years, and it's frustrating when things just don't add up. And medically, it was very complex, and I don't think they have an answer even to this date. But the hip plus discoloration plus RSD, complex regional pain syndrome, sweaty, pale, autoimmune disorder. It's just started at a young age, and I feel like I was just part of a chapter that we don't understand yet. But over everything, you got to understand what the environment is. Ask better questions because you never know what's hitting you. Don't assume musculoskeletal is musculoskeletal. Rule it out and then understand the environment before you start getting frustrated with yourself or the athlete. And like it doesn't make sense. It's your fault. Like, why aren't you getting better? That's not the case. Sometimes it's beyond them, especially at 13. They don't understand anything. They're trying to figure out themselves and their body, and they can't understand what pain means. Their threshold is different. So I'd be more patient and start doing research early when I see things that just don't add up musculoskeletal wise. I tell my team that all the time. If it doesn't add up in the first 3 to 4 sessions, start looking at research, start talking to the parents, start talking about the home environment, start talking about who they are, how that child interacts, what's their school environment like, how do they act, because you got to see, is it musculoskeletal or not, and how you can help this person. They're asking for help. It's just what type of help. That's very deep for some of you who are looking for maybe how to get better ankle or hip or knee outcomes. Just set the framework a little bit better, and understanding that not every case is straightforward. It's not a straightforward knee or a straightforward hip. And then what do you do with that? Do you just throw it out and say like, oh, it's not musculoskeletal, see you next week or find somebody else? I think it's your duty to help people point you in the right direction. And if you love what you do, you'll do it too. All right, guys. I hope that helps. I mean, there's super complex cases that have changed my game and how I approach people. So I hope that helps with your overall framing and what you do. So there you have it. It is New Year's Eve. I'm going to hang out with my family. I'm going to have some delicious Mexican food, and I will probably be asleep by 8:59 tonight. So I hope you guys have a great time. 2021 has been an amazing year for me. A lot of ups and downs, personally and professionally, and I am very blessed. And I hope that all of you, wherever you are in your personal and professional lives, understand that you're all going to have to hustle and grind, and you might be in PT school and you're going to have some challenges. Like, things aren't easy, and you're going to find a job that you maybe don't enjoy or work with people you don't love. um, Understand that there is light at the end of that tunnel. You're climbing a hill that you're looking up and like, man, this seems rough. I got to do this many times, or these many patients, or this, I got to see this athlete, or, they're not easy. I can't understand this case. Ultimately, you're looking up, but sometimes you got to like turn around and look at like the hill you just climbed to get where you're at. And that's what, sometimes the end of the year kind of helps you reflect on that. Like, it's been an amazing year. Despite the ups and downs, like I'm still looking down at like what I accomplished. Yeah, 2022 has got a big hill in front of me, but relax, like enjoy what you just did. You're here on this podcast, you're in PT school, you're a new grad, you're established, veteran PT. Whatever you're doing, enjoy what you just did. 2022, for me personally, I'm gonna crush this. If you want to be in my world, you gotta come to these seminars. I got 5 of them coming up this year. And if you're looking to help with that extra push coming up that mountain, I'll give it to you. Anybody in my world, you know how much I love pushing you to, conquer whatever it is that you want to do professionally. I understand that most of you want to be really good at your craft, and some of you think that you need to be good at, taping or whatever it is. Sometimes you need a second voice, somebody behind the scenes saying like, I wouldn't do that. I'd stay the course here, move this way, whatever it is. So, congrats to everything you did in 2021. Be proud of yourself. I am very proud of my team and myself for who we are today. We had added a second clinic to sports performance this year, and that is takes a village to make that happen. I'm proud of my team and everybody who's been on that journey. And now in 2022, we're going to attack, both live and online support, leadership, mentorship for all of you guys and you guys and girls who are looking for help and support that for some reason this might not exist in your world, or maybe you like everything that I've gone through and you want to be part of that, or you live in San Diego or Southern California, and that's the next step for you. Cool, I'll help you out. Let me know where you need me. Dr. Chris at Dr. Chris Garcia. I hope to see you on March 12th and 13th for the first course in San Diego. 10 slots available in person. If not, go virtual. Happy New Year. Enjoy everything that you've done. I hope you spend it with your family, friends, anyone you love, and be safe out there, guys. Enjoy the time. Be safe. And I'll see you guys on the next episode. Take care.